Okay. Pointer illa. Good morning, respected chairpersons, teachers, my dear friends. So I will be talking on biomechanics of shoulder joint. Biomechanics was a very difficult topic for me during my PG times. And it was very hard to learn also. And the book I hated most was that book on biomechanics, but Cynthia Hawkins. But learning biomechanics after learning these clinical things, what is the cause for subluxation, what is the cause for impingement, then the reverse learning is more efficient than learning biomechanics first, then learning clinical things. So it is the reverse thing that helped me a lot than learning biomechanics first. So I will just try to explain something about the shoulder, biomechanics of the shoulder joint. As you all know, shoulder joint complex, when we are moving, it is not only the glenohumeral joint we are moving, as you all know, it's a complex movement. So all things, the glenohumeral joint, the sternoclavicular joint, the scapulothoracic joint, and acromioclavicular joint come into play. And as you all know, glenohumeral joint is a ball and socket joint, and the sternoclavicular joint is a saddle joint, and scapulothoracic joint is actually not a true joint. So, and also the humeroarticular joint is also not a true joint. So it's a shoulder joint consists of 4 joints. And as you all know that the humeral head is large and the glenoid fossa is small. So there's the ratio 4:1 between the humeral head and glenoid fossa. So joint is incongruent. So what happens is that you can have more of it is not a stable joint. You can have more of a movement. You can have movement in all planes. And the stability of the joint is not much. So you're compromising stability for the mobility. So as you all know that glenoid fossa is pear-shaped, and that is important. So the joint, humeral head is actually, should be kept in the lower part. And the labrum is actually increasing the congruity of the joint. So the joint is made more shallow by the labrum. And labrum gives attachment to the ligaments also. So there are ligaments that are attached to the labrum and capsule also. So there is the superior glenohumeral ligament, middle glenohumeral ligament, and the inferior glenohumeral ligament that is attached to the labrum. So this stability of the joint is mainly by the ligaments, muscles, and the other structures. So as I said earlier, shoulder joint gives mobility in 3 planes, mainly in the sagittal, coronal, and transverse plane. So in a sagittal plane movement, what is happening is the flexion and extension. This is sagittal plane, and the axis is the coronal axis. And frontal plane movement is mainly adduction and abduction is in the frontal plane movement, and the axis is in the sagittal axis. And transverse plane movement, that is the internal rotation and external rotation, and the axis is the transverse axis. Similarly, as I said that the ligaments, that is the superior glenohumeral ligament, middle glenohumeral ligament, and the inferior glenohumeral ligament. Inferior glenohumeral ligaments are actually having 2 parts, that is the anterior glenohumeral ligament and the posterior glenohumeral ligament. And there is an axillary pouch. So the ligaments will be lax during the mid-range of movements, but it will be taut in the end range. So when the shoulder is in the adducted position, the superior glenohumeral joint is actually preventing the posterior dislocation or inferior dislocation, because it is attached to the superior glenohumeral ligament is attached to the superior part of the labrum and the lesser tuberosity of the humerus. Then when the shoulder is abducted to 45 degree, the middle glenohumeral ligament that is attached to the labrum and the capsule of the where the supraspinatus tendon is attached. So that is the middle glenohumeral ligament. So at 45 degree of abduction, it prevents the posterior subluxation and inferior subluxation. Then the inferior glenohumeral ligament. So when we are falling on the abducted and external rotated hand, that is the way we fall, that abducted and external rotation position. So this inferior glenohumeral ligament anterior band will prevent the anterior subluxation. So during anterior subluxation of the shoulder, this is the inferior glenohumeral ligament is actually injured. And when the shoulder is abducted above 90 degree and 180 degree, the head is accommodated in the axillary pouch. Then something about the angle of inclination. So what is angle of inclination? So angle of inclination is the angle formed by the line passing through the head of the humerus and the neck, and then vertical axis through the proximal humerus. So it is around 130 to 150 degree. Then angle of torsion, that is whether the femoral head is retroverted or anteverted. So this angle is formed between the line passing through the head and neck of the humerus and a transverse line passing through the condyles of humerus. So it is 30 degrees posteriorly. So the head is actually retroverted. Head is medially directed, superiorly directed, and it is posteriorly directed. So there is a 30 degree of retroversion. Now about the stabilizers. So how the joint is made stable. So there are the static stabilizers of the shoulder and the dynamic stabilizers of the shoulder. So as when the shoulder is lying hanging free, actually what is stabilizing the shoulder? It is not the muscles, because muscles are not active at rest. We all know that energy conservation is main thing. So muscles won't contract when the hands are free. The tone will be there, but there won't be muscular contraction. So muscular contraction is not stabilizing the shoulder joint. It is actually three things. One is the rotator interval capsule. Second one is the negative intracapsular pressure. And third is the inclination of the glenoid fossa. So what is rotator interval capsule? So rotator interval capsule consists of the coracohumeral ligament, superior capsule, and the superior glenohumeral ligament. So these three, what will happen is, you can see that pointer, right? Sorry, pointer is not working. I'm sorry. Back. Kurchum back. Alla, I'm back. കുഴപ്പമില്ല അല്ലെങ്കിൽ
അതിൻ്റെ സോഫ്റ്റ്വെയർ
നോ പ്രോബ്ലം.
സോഫ്റ്റ്വെയർ ഇതിൻ്റെ
ഇല്ല വേണ്ട കുഴപ്പമില്ല.
അല്ലടാ ഞാനിപ്പോൾ നേരത്തെ ചോദിച്ചത് സോഫ്റ്റ്വെയർ.
No problem. So actually the rotator interval capsule, what is happening is that there is a superiorly directed force. So this gravity, when the gravity is acting downwards, so there is a superiorly directed force that is by the rotator interval capsule. So the force vector will be directed towards the glenoid fossa. So that will produce a compressive force that will keep the that will keep the humeral head in the glenoid fossa. So, as you all know that when we are having in hemiplegia, what is happening is that there is a increased gravity is acting downwards, and this rotator interval capsule, which is actually a soft tissue. So it is actually stretched. So this soft tissue has a property. So when it is when it goes into plastic mode, the stretching is that contractile property is lost. So this constant stretch of this capsule will produce this inferior dislocation. Second thing is the negative intracapsular pressure. So actually what is this doing is that it is an airtight compartment. When this vacuum is there, the humeral head is sucked into that glenoid fossa. So that is why then when there is a small labral tear, what is happening? The stability is lost. That is why we want to repair the labrum. That is the cause why we repair the labrum. It is due to the loss in the intracapsular pressure. Second and the third one is the inclination of the glenoid fossa. So actually the position of the scapula has an important role in producing the stability for shoulder joint. So actually the glenoid fossa is slightly tilted upwards. So that slightly tilted upward glenoid fossa will give some sort of stability to the shoulder. So in persons whose glenoid fossa is congenitally little downwards or inclined downwards, the shoulder will be unstable. So these are the static stabilizers of shoulder: rotator internal capsule, negative intracapsular pressure, and the inclination of the glenoid fossa. Then what are the dynamic stabilizers? Dynamic stabilizers are the muscles. So muscles, deltoid muscle is the main prime mover. Then the rotator cuff muscles and the long head of biceps. And also scapular muscles, periscapular muscles like the trapezius, then the trapezius, then serratus anterior and pectoralis major. So deltoid muscle, as you all know, it is a large muscle. It has three components: anterior, middle, and posterior. And actually, what the force vector is actually directed upwards. Force vector is directed upward. So when you resolve it into two components, that is there is a parallel component and there is a vertical component. The FX component, which is the largest component, so that FX component is actually directed upwards. So what happens when the deltoid is contracting? What is happening? There is actually a translation. So when there is a translation, the deltoid cannot do an abduction. So the head is actually translated upwards and going upwards, so that abduction is not possible. So when the deltoid is acting isolatedly, when there is no rotator cuff muscles, abduction is not that efficient because of this translatory movement which is directed upwards. So how this is counteracted? This is counteracted by the itis muscles. So these itis muscles are the infraspinatus, teres minor and subscapularis. So you can see that force vector is directed towards the glenoid fossa. So there is a compressive force that is directed towards the lower part of the glenoid. So that is providing the stability so that the deltoid can act. If that is not there, what is happening is that the deltoid, the head of the humerus is going up. It is translatory movement is there, and it will prevent abduction. So this itis muscle will keep the head in correct position so that deltoid can act. So similarly, this vector is also having a parallel component and a downward component, perpendicular component, that is FX component. So as you know that the FX component actually, this downward component can be balanced by as I said earlier, there is an upward component of the deltoid that is balanced by this FX component. So that is the role of this itis muscle that will keep the humeral head inside the glenoid fossa. So this is the concept of the force couple. So force couple means the force of deltoid is acting entirely the opposite to the FITs. So what it is producing a force couple. That force couple will produce a rotatory movement. So actually what we want is an rotatory movement, and we don't want a translatory movement. So this rotator cuff muscle will keep the humeral head inside the glenoid fossa, and the prime mover will produce abduction or flexion. So that is how it acts. So that is why this is very important for rehabilitation. For rehabilitation, you should not strengthen the first your priority should be to strengthen the subscapularis, teres minor, and this one infraspinatus. So that will give the stability for the prime mover to act. Similarly, supraspinatus also. Supraspinatus, actually, you all know that the force couple, it is having a parallel component and a vertical component. The parallel component is the FY component, and the vertical component is the FX component. So this supraspinatus is a small muscle, so this FX component can be balanced by the gravity. Whereas deltoid is a large muscle, so that component cannot be nullified by the gravity. That is nullified by the infraspinatus, teres minor, and subscapularis muscle. Supraspinatus being a small muscle, this FX component can be nullified by the gravity, and the force, you can see force vector is directed towards the glenoid fossa. So actually supraspinatus is having a larger lever arm. So it is actually biomechanically it is more efficient than the deltoid. So supraspinatus also can produce abduction. Then long head of biceps. As you all know that long head of biceps passes through the bicipital groove, then it pierces the capsule and is attached to the supraglenoid tubercle of the glenoid. So actually anteriorly this biceps is attached to the supraglenoid tubercle of the glenoid. Posteriorly long head of triceps is attached to the inferior infraglenoid tubercle. So that is producing some stability. Then the scapulohumeral rhythm. So position of the scapula is very important for producing the stability of the shoulder. And the scapulohumeral rhythm, as you all know, that is a 2:1 rhythm. As I said earlier, when you are you are producing flexion or abduction, it is not only the glenohumeral, there are other joints are also coming into the play. And the scapula, there is a 2:1 rhythm. When the flexion is around 100 to 120 of the glenohumeral flexion, and the remaining 50 to 60 is by the scapulothoracic joint. And scapula is having also there is posterior tilt. There is a posterior tilt is there, upward rotation, then protraction. A protraction is there. So what happens when you are just flexing? There is some internal rotation, then there is an upward rotation, then is some retraction is there, and a posterior tilt. So position of the scapula is also very important in maintaining the shoulder, for giving the stability to the shoulder joint. Okay, thank you.